Boleh dengar? You cannot hear me? You cannot hear me? Tak boleh dengar? What is this?
Nurina, betul kan you pun tak dengar?
Oh.
Dengar suara Dr. Aili.
Nurina, you boleh dengar tak Dr. Aili? Ke I yang tak boleh dengar?
Dengar, suara Dr. Aili dengar.
I was thinking of, okay.
Dr. Aili, try again.
Assalamualaikum. Boleh?
Oh, I lah yang tak boleh dengar. Sekejap I lah yang keluar dulu. Okay.
Okay, we can hear you.
Okay, I also can hear you.
Okay.
So far, we only have Dr. Paran. Hi, Dr. Paran.
Hello, Dr. Farad. He's not on.
Can we
Yeah.
give another 5 minutes?
Boleh. I'm okay.
Ke semua orang takut nak dengar Dr. Aili kata mencabar ni. It's very challenging for this session.
No, because you see, I think doing child and adolescent memang challenging kan. Susah.
Yes.
But it's also a huge bulk of the patient. That's why bila you all nak buat ni, I was thinking, okay. Ada orang yang kita boleh minta tolong to handle child and adolescent.
Yes. So who are in your team? I mean, if it is psychiatry, the general psychiatry, they always have the occupational therapies. Do you have any extra people that solely tackle the children or the parents?
I do. When I was in UMMC, I had my 2 counselors, which have been with me since I started the unit in the year 2000. So they have been with me since the year 2000.
Alright.
In other places macam HKL ataupun other general hospitals, but they under KKM. I think they have clinical psychologists.
Okay. Do you collaborate with, schools, for example, is bully issues or don't want to go to schools? How do you put these other people in your circle of counseling?
Since the year, I think that since which year, I have worked with the school counselors I offered to 10 schools in daerah Petaling Jaya, is that Petaling Utama, is it? Okay. So these school counselors, they have been with me sebelum COVID tu. We all meet every month or every term tu. So they bring up cases for discussion actually.
Okay.
So my aim was I felt that going to schools and giving talks, it's too big a group. I cannot reach out. I mean, I would not get them to hear what the message is.
Okay.
So by having a small group, what I did with the counselors in the schools is to get them to change. Macam ni lah, the talking therapy, get them to change their perception of how to handle kids, adolescents. Yeah.
Because I'm afraid, general population, me myself not included, not excluded. We just think that the children are degil ke, kan? We don't go beyond that or deeper than that. It's just degil.
Correct. Correct.
The children kan.
Yeah, you're right. Then I think part of that is one is our experience, kita punya where we learn our parenting styles, or our own experience itself as a child. right? But then because of knowledge and whatever research that has been done, I think there are other ways of managing kids.
Yeah. And
Not
for
the
parents
easy.
also, and parents also sometimes they just think that jangan bagi muka ke kan, jangan biar anak ngada-ngada or pijak kepala. They don't go beyond the psychological part of the children, maybe.
Yeah, betul.
Mm. So it's very challenging, kan? Child psychologist. Okay. I
Yes.
think we should start now. We have given a leeway of 5 minutes, but in
Okay.
respect to our attendees, so I think we'd better start now. Assalamualaikum, good evening. I bid to Dr. Aili and all our participants. Today is the last session in the series of CME conducted by Selangor government through its program Selangor Mental SEHAT with the collaboration with IIUM, International Islamic University Malaysia, and also Malaysian Psychiatrist Association. I am Dr. Faiza, your moderator for today, and with me is Dr. Aili Hanim binti Hashim, the consultant adult child and adolescent psychiatrist, who is currently practicing in the mental faculty.
The mind faculty.
Sorry, the mind faculty. Okay.
Yes.
Welcome again, Dr. Aili. She has
Thank
been
you.
with us last week and she has enlightened us in many, many aspects of child and adolescent psychiatry. And today she is back with us again with another interesting topic and also hopefully the skills that we can adopt. That is the talking therapies, and in particular to the children and also the adolescents. And welcome back, Dr. Aili.
Thank
And
you.
without further ado, I pass the session to you.
Right, let's see. Okay, you have to give me the sharing screen.
Yes.
Okay, thank you very much. As just now, Dr. Faiza and I were discussing that even as parents ataupun as therapists, we tend to use ways that we are used to. Okay, so what I'm trying to, what I will try, kalau boleh, okay, it's a little difficult. I'm trying to give ideas of how to manage kids differently. Okay, I tried this with the school counselors. I've seen them quite regularly. Before the COVID, they come in, they bring in cases. Interestingly, they brought in their discipline. Each school, they brought in their discipline teachers, and then they also brought in their headmaster or admin people, mainly to get these people to understand about mental health difficulties in children, anyone below 12, below 18, and as well as how to deal. Kalau kita tengok kan, in schools, and through my years that I did when I was working in UMMC, we get feedbacks from, not only for the teachers, we also get feedback from the kids, as well as their parents. And many of them, they feel very difficult to trust counselors or lagi discipline teachers lagi dia tak trust because of the way that we manage the children. Okay, what I am hoping to get you all interested in, right, to look at different ways of handling these children. Okay, now I purposely put it here. Let us do something for our kids, and this is a motto that I've been trying to advance, partly because we need to do and handle our kids differently. Now, this is your role, okay, to think about as a primary care physician, how can you conduct, or do you have the time and space to handle children, because this is very important. Okay, for me as a psychiatrist, I have to admit I use the biopsychosocial approach. And what does it mean? I use medication on top of the talking therapy. And in kids who are depressed, even if you do the talking therapy and the depression doesn't lift, then there is always an opportunity to use medication. I can't run away from it because there are kids who are very depressed. Okay, so talking therapy, what is it about? Okay, sorry. There are various forms of talking therapy. Okay, one of it I always ask is where to start and when do we start. I think the answer will be clearer as I go on. Okay, one of the issue that we do, or the situation, ways that we do, and this is why I did it with the school counselors, is that we tend to give advice and we provide a lesser providing reassurance. The advice giving is quite common, yeah. But what studies show is that such interventions are usually short-term relief. So we talk about, can we make it long-term? And I'll talk about it later, but what it means by long-term. So that whatever it is that we communicate or we use in the sessions with the children, eventually it will be their decision, for example, or their ways of changing their behavior, for example. Okay. Now, what do I do here is that the alternative to just giving advice is to try and engage them to start thinking about problem solving or how to solve the problems for them somewhat. Okay, with them, sorry. Okay, and how to do this is having this idea of, instead of giving advice or instead of automatically giving advice, here is we try to understand, why is this child here? Why is this child in front of me? And many times I do things like, or we are asked to do things like reflection, validation, listening. And then while we do all this, is picking up the hidden story behind why the child is here, their presentation, including picking up their pains, right? Even if we do this and we can or trying to understand, I do a lot of validation, encouragement, as well as reflect. Reason why? Because for me, the therapy starts, and the stance that I take is the minute that I see the patient, right? That's when I start to do my therapy. Okay. And my therapy is based on knowledge and evidence base. Okay. So when I do this, knowledge and evidence base, it's not from my own it's not from my own expression. It's not my own what I decide about what I see about the child. For example, the child not going to school, for example, it's quite common for us and natural for us to think, oh, budak ni malas ke, right? But if it becomes knowledge and evidence based, I should be thinking about, why is this child not going to school? So that biasness or name calling or giving this child a name, for example, I'm moving away from this, being judgmental, being biased, and I'm moving away from giving advice, playing a parent role. Okay, so this is what I do when I handle children. Okay, and my knowledge base is based on the psychodynamic theories that I've learned, the human development, including scientific evidence of parenting styles and parenting behavior. Okay, so all these are evidence-based. Okay, so I'm moving away from, okay, I know everything about you, so you do whatever I say. No, I don't do that. So I'm moving away from, hey, help me understand, why is it that you're not going to school? Or why is it that you're arguing with your friends and your parents? Okay, so I'm moving away from talking to them, giving advice, to listening and understanding, right? As I'm listening, I'm understanding or trying to understand. I'm also trying to figure, or what I usually say, to fit the jigsaw puzzle about this child that I see in front of me. And so what I do here is I develop the insight to see what are the changes that has to be made. So this is what the psychodynamic understanding. So how psychodynamic works is for the therapist, right, to gain insight about what it is the problems are with the child or the adults that we see, right? And we turn this insight that we have regarding the patient into action and therefore management. So as we are doing this, the psychodynamic theory talks about eventually turning the insight of the patients or the child, so that it is via the child's insight that they develop insight to why they are struggling, and hopefully, as we are interacting with them, we develop this therapeutic alliance so that we can turn insight into action, so that eventually the children manage themselves. Okay. Unfortunately, it has to be repetitively done. Okay. So it's not seeing, so if you give advice, it's once or twice or slightly more than that. But if you're doing this therapy to try and develop their insight from our insight, it has to be repetitive. Okay. So for me, the talking therapy begins trying to understand the difficulties first before I go into any form of advice and so on and so forth. Okay. These are things just mainly some evidence-based, and childhood disorders can be treated, particularly depression and anxiety or phobias, yeah, but it has to have the appropriate diagnosis and appropriate treatment. Okay. And as what I said earlier, and the delay or why kids will eventually stop coming is because adults have this opinion that the children is not trying enough, hard enough. So, or the child is attention seeking. So this labeling, it doesn't help, right? So we are giving them an opinion before understanding what the child is struggling. Okay, so these are things. All right. Now, again, I'll just have to reiterate that very much the relationship of children with parenting difficulties, yeah, has an increased risk of mental health difficulties, and there is growing literature to talking about parenting, how parenting practices have negative childhood outcomes, right? These are some of the things that you see, and I will see it, and I see it as well in my practice: the depressed parents, the anxious parents, alcoholic, definitely. Now, this is the thing that I find over the last couple of years: parents with this aura or negativity, parents who are rigid and not open to ideas, abusive, controlling, dismissive parents, and parents who are impatient and have poor anger control. Okay. Now, why do I keep mentioning about parents? Because the evidence is associated with mental health difficulties in children. And if you look at ICD and DSM, yeah, they use codes. Yeah, there are codes, the Z code and the V code, whereby you formulate it into your diagnosis. So it's not just major depression, but it's major depression related to. And why I use all these codes is particularly to remind me that on top of helping the child, I would also need to consider help for the parents. So and this is how, when I say understanding of the child, I try to tease it out how parenting roles or not, or family factors play a role in how the child is unwell. Okay, so where do we begin? Right, remember when I said to you, right, the minute that I see the child, right, I will try and finish this up as soon as I can, mindful of the time. Okay, and this is exactly what I do actually in an hour, because I'm so used to, you have to take your exams, and our exams are about an hour or less clocking. So what I do is I do this in my real life assessment of kids, right? So when the child comes in, yeah, I talk to them about what are their current issues, if there are triggers, yeah, looking at, okay, so things like, so when did the child fall ill, right? When did he become unwell? Looking at possible stressors. Now, not just possible stressors, yeah. I talk about, I think about, why are these stressors stressing for the child or the family, right? So I go back here. So a child might come in depressed. I look at triggers. It's not just a name. I ask myself, why are they triggers for the child, right? So I look at, even they come here, I move backwards to try and understand. Backwards means I go as far back as their childhood, and then I pusing balik to see how is it like for them as an adolescent, young adults, and so on and so forth. Okay, so you can see this, backwards and roundabout turn back is basically for me, like, I want to know you, tell me more, right? So, and when I do this, many a times parents or the children will say, the children are okay, because I try and do it as less less stressful manner. But many a times the parents will say, so when are you going to assess my child? Not knowing that the questions that I ask, I am already assessing the child. So things like, what are the stressors? Has it happened before? Right? So if a stressor happens, right? So what happens to the child? How does it affect the child? Thinking about a psychiatric diagnosis, right? So when people talks about malas, I try and see whether malas belongs to a psychiatric diagnosis. Where can malas be psychiatric diagnosis? Malas can be a psychiatric diagnosis in the child having neurodevelopmental disorder. Malas is a psychiatric diagnosis and symptom of ADHD, neurodevelopmental disorder. Malas can be because the child is depressed. Yeah, malas can be because parents do not teach the child. So this is what I'm thinking about. So I'm moving away from being biased and judgmental. I'm moving towards looking at, is there a medical diagnosis in this child as well as in the family? And to help me, and that's why, see, when I go this way, and then I pusing balik. So when I pusing balik, it means I am already trying to figure out whether the ideas that I have will fit in to what I hear from the history and in the ideas that I have. And how does it done? How is it done? Because if you take the child's development and the family history, you can understand why the child behaves as such. Okay, so this is what I do. Now, many a times, when I listen or look at, when I'm listening to the child, I'm looking at the child, and I try and respond as much as I can. Yeah, of course, sometimes it's difficult because I'm writing in notes. Yeah. And when the child tells me something, for example, I didn't feel like getting out of bed, right? Instead of saying, okay, dia malas kot, pergi sekolah, dia tak suka sekolah kot, I will ask, tell me more. What do you mean by you didn't feel like getting out of bed? I don't get a response. So then I will ask, is it because you feel tired? Or were you not sleeping well last night? Or tell me, what time do you usually sleep? And what time do you sleep last night? Why are you sleeping late, for example? And I ask these questions, but not in a robotic manner, basically to identify what possible psychopathology there is. I give it a name, or what I usually tell my students before, you put it into a basket, but the basket must have a name, right? The basket must have names like, as what I said earlier, is it a neurodevelopmental disorder? Is the child depressed, right? Is the child having anxiety? Because whatever basket that it goes in, right? When I turn and stop to think, there must be enough ingredients in that basket for me to come to a diagnosis. Okay? So, right. Same thing again, right? At the same time, why do I do this? Why do I do this thinking? Why do I pause? Why do I respond? Okay. Why do I speak in a manner that, hey, tell me what's going on with you? Is basically, and this is what the theory talks as well about, to show some form of empathy and humanity. Reason, because it is for the kids, seeing things like this, it helps in the therapeutic alliance. Okay, why? I'll tell you why shortly. Okay, what does it mean? Because, okay, in cases like this, right, we have to provide this experience for the children as well as experience for the parents to try and help their kids. Reason, because many of the kids grow up in an environment whereby they're not being heard. They're not even asked. They're not even allowed to speak up. Yeah. And many parents do not have that experience whereby they allow their kids, or many of the parents, they come from their homes themselves whereby they have not been assisted or allowed to speak or learn or be heard. Yeah. So here is the experience here is to try and give parents as well as our kids a different kind of experience. Okay, why? Now, Andrew Wade was my former supervisor. And what he talked about is children needs. What does children needs? Children needs to feel safe, an environment whereby they feel safe, whereby their basic needs are met, whereby the adults in the children's life are united enough so that they feel loved and cared for, and parents are able to reflect enough, right? Reflect instead of just commanding the kids to do whatever it is they want the kids to do. So when all four are in place, invariably, the child knows their place within reasonable boundaries. Unfortunately, in many households, the kids' basic needs are met. Many of them have enough food, they have enough clothes, right? Some branded clothes or branded goods, but they come from homes that they don't feel safe enough, whereby the adults are not united enough. They don't feel cared and loved enough. And parents are definitely reactive instead of reflecting. Okay, so because of that, many of these kids will have difficulties with emotions as well as behavior. And many of the children, and we talk about the attachment theory, many of kids grow up in insecure environment, right? Resulting in insecure attachment related to parenting styles and behavior. Parents are not available or reliable enough. Interactions with parents are physical, probably. Some of them no. Emotional, definitely not. Interactions with parents can be chaotic, can be hostile, and they come from homes whereby question who is the role model, where is their support system, right? So these are things that are missing for many of these children's home. And what happens then? Okay, so this is what I look out for, and this is what I do, and eventually tackled in the therapy is their self-esteem, self-regulation, and self-direction. Okay, their cognitive, how they think about themselves, how they react, trustworthy, they don't have. They come from homes whereby it's not trustworthy enough. And therefore, their relationship, if their relationship with parents are hostile and chaotic, so will there be their relationship with other people. I remember seeing a young adult yesterday, right? And she is in a relationship with her boyfriend since high school. And despite them being in a relationship since high school, there'll be about 7-8 years now. But that relationship is so unsteady, right? And then she was discussing with me in terms of what she grew up with, whereby in a household whereby the parents are always unavailable, parents are always fighting, and she remembered a time whereby the father would ask mom to pay back for whatever it is that she spent on the children, on the household, right? And then she was talking, and then I said, but do you think how your relationship or how you see your parents is how you and your boyfriend has, the relationship that you and your boyfriend has? And she looked at me and she said, I don't trust my boyfriend. Why do you not trust your boyfriend? And then she remembered she couldn't trust her boyfriend because she's never trusted her father. And growing up being the eldest daughter, right, she's always need to support her mom. But at the same time, mom wasn't able to support her. So she grew up in an environment whereby it is unavailable, there's no trust. And this is the template that she has. And invariably, this is the template that she carries on into her adulthood, right? Including the low self-esteem, right? The relationship with others, which is a lot of distrust. And how does she adapt in crisis? She adapts in crisis, breaking down with self-harm. Mind you, this is not an adolescent, this is an adult. So if we understand, many of our clients come from homes whereby they're not heard, they're not understood, they're not allowed even to think or verbalize whatever it is that they think. They're not even allowed and not even taught to learn from their mistakes, but they're constantly punished. And the significance is that when they come into the room, they come in with therapy with us, right? They might also think that we are doing the same thing as their parents, meaning that we are going to talk over them. We're not interested to listen to whatever it is that they're saying, right? We are going to tell them what to do. And what is the significance of this? That's going to affect the therapy with the child. Okay? Okay, pause. Any questions for now? Nope.
So far tak ada ni, semua faham ni. Dr. Aili explain clearly to us.
Okay, so what I do, let me give you 2 scenarios. Okay. Even though it's 2 scenarios, but you see it's about the same. 16-year-old child, 16-year-old girl, she's schooling, staying with the parents. Parents are working, brought in the child for help 1 year ago for self-harm, feeling anxious and depressed. Right? Or the 16-year-old going to school, staying with the parents again working, the same scenario. Okay? And the child has not received help. Okay? One has received help and one has not received help. Same complaint. And I have to say, these are the same situations that I see week in and week out. Same case scenarios, right? So one of the first things that when a child like this comes in, I have to tell myself, buckle up. Yeah, buckle up means don't just say whatever it is that you want to say. Things like, instead of saying, kenapa ni? Cut yourself. I would say, hey, I see that you have scars on your hand, for example. Okay, because invariably you can see it, right? Or you can say things like, what's going on with you? Tell me, yeah, wanting to know. Okay, so I talk about what is the chief complaint. I try to explore. I look at their childhood past history. I look at the family history, and then I put it all together. Basically, it's just like a jigsaw puzzle, right? And I never take things like when it's, yeah, my family is normal. What does normal means? Right? So I use this opportunity to have or to start this conversation. Okay, why? As what I said earlier, many of them come from an environment whereby to have a conversation or their normal conversation is to sit and listen. Okay, so these are things, you're going to have my slide later. Oops, hang on. Okay, this is what I do. So again, you can see, and what I did in these slides, yeah, I gave the different scenarios. For example, a child comes in feeling angry, right? So I will ask things like, I said, instead of why are you feeling angry, I will say, since when have you been feeling angry? I want to know why, right? So let's say 16-year-old girl, for example, since when have you been feeling angry? Since 1 year ago. Okay. So I want to know, your choice is either you look for symptoms of depression, mindful that in adolescence, yeah, it's not sadness, but this irritability is most commonly seen in depressed adolescents. Or I can say things like, 1 year ago that you've been feeling angry, how were things for you then? Okay, mindful at 16. So 1 year ago, minus the pandemic, or with the pandemic is even worse, yeah, they will be in Form 3. Okay, why is this important? So I need to know significant child development. So I take into mind things like 12 years old or standard 6, Form 1, 13 years old, 15 years old, 16 or 17 years old are stressful times. Okay, so this is my idea. And instead of assuming that exams are stressful times, I would say, just to get the conversation going, why were you feeling depressed, or why were you feeling stressed when you entered Form 5? And then that's Form 5. Okay, remember when I remember that diagram, I keep moving it backwards. So what about Form 4? Right? How were you in Form 4? Okay, so if they say things like, okay, I was kind of okay in Form 4, but you were not okay in Form 5, in my head, I'm thinking about, why is she not okay in Form 5? Okay. Now, if I can get a somewhat of a timeline, then I would say, what is it about being in Form 4 or Form 5 that's depressing for you? What was happening for you? Right? What happened then? Because I want to know what are things that has worsened the depression. Okay. Now, all this while keeping in mind, I'm trying to build this therapeutic rapport with the patient. Okay. Why? The reason why, right, is I want to check my hypothesis. And the other reason is what I said earlier, kids come from homes they're not being listened. So we're giving them a different experience. And why is it important to give them that different experience? It's important to give them the different experience to show them that, truthfully, we understand a child needs to come from a home whereby it's supportive and so on and so forth. You don't get it, but it doesn't mean the rest of the world is like this. Right? It doesn't mean the rest of the world is like this. It means there are different ways, a different environment that you come in from. Now, mindful of the fact that I'm doing this not just with the child, but I will do similarly with the parent, even though it's much more difficult with the parents, but I still need to give a try, because eventually we want to try and give the parent back the child, right? Parents invariably sometimes, and I've had many times over the last couple of years, that the parents say, okay, this is my child, you look after the child. But not just here, but the theory says, no, we're not going to take over the parenting. We will have to establish whatever it is that we need to do, to get back the child back on track. And this is based on theory. And the theory says, we have to develop this rapport. I particularly added in the empathy and humanity because we've lost it. We've lost it. Well, I think I said last week, I'm not seen as a good friend to many parents is because they don't have this, right? And they feel upset if we were to say things like, there are things happening at home that I think needs to be worked on. Okay. Now, similarly, with the parents, so these are just examples for you when you look at your cases, right? Instead of low self-esteem, full stop, right? I'll be asking, why is this child having low self-esteem? And it does. There are many theories that tells you, and one of the many theories that helps you fix this problem, fix this jigsaw puzzle is the attachment theory. Okay, these are things. So I'm just leaving it here, right? To give you examples of some of the cases that you might be seeing. So what happens then? Okay, so what happens then? This is where I try and fix the jigsaw puzzle. I formulate from the presenting complaints. I look back into possible difficulties in the family, giving rise to interpersonal styles, self-esteem, so on and so forth, right? So I do a form of formulation. And what it helps is my formulation is theory-based, and therefore I can present this to the parents to say, look, there are times whereby things have been difficult in the family, and what has happened here is that the difficulties in the family has contributed to the child feeling low self-esteem or feeling unsure, precipitated by her difficulties in school, she's been bullied, and so on and so forth. So I sort of present a simpler formulation, right? Or I break it down to give a basis of why I think this is how I'm going to manage the child. Okay, Kabani's, again, a very popular psychoanalysis, talks about how the key factors that we try and tease out when we manage the child is if we can discuss and identify the primary problem and the patterns. See, if you get your diagnosis correct, so of the problems, You can see it in recurring patterns. For example, difficulties in handling oneself, right? So it might come as a presenting complaint, but as you take the history, right, you can see the recurring pattern. And these recurring patterns, you link it with the person's developmental history, right? Then your diagnosis or your idea, your formulation of the person is usually right. Okay? So these are things that you can think about in terms of what you're going to do in your, okay, so in your, for example, management. Okay, I purposely, okay, even though it sounds difficult, but many of these kids, invariably what I do is trying to get them to think about problem solving. Why? Because when they come from homes whereby parents are not available, either they're busy or they're fighting or so on and so forth, okay? In the child's development, many of these kids grow up never knowing how to solve their own problem or what it means by problem solving. Remember when I said earlier, this aura of negativity, right? So we're talking about, jangan buat ni, jangan tak boleh buat ni, tak boleh buat tu, tak boleh, you know. I have a child who is, unfortunately, she's 15, and she came to me probably beginning of this year. Maybe I saw her 3-4 times. Sorry. And then the father has stopped her coming. And the main reason that the father has stopped her coming is he doesn't believe in mental health, right? And he does whatever it is. I made an appointment to see her, I think 3 or 4 weeks ago. When we called him up, he said, so sorry, he's so busy, he forgot about the appointment. So this is resistance, right? And the child is so wanting help. She's depressed and she's suicidal, okay? So what I do is when the opportunity, when I do have time with the kids, I talk to them about problem solving, okay? Why? Okay, this is just basically, if you can understand, for example, what I do. Okay, this is an example, okay? I do this not just in adult, I do it in young adults who can sort of understand what's going on with them. So I will say things like, what do you think you, in terms of your personality, how would you describe yourself? Okay, I leave some of these common things here because I already know in the history what is probably like. So I'll talk about, are you a worrier? Do you feel anxious often? Yeah. And then I show them, and they get to do it with me. What their personality is like, right? How their childhood experience is like. And then I move on to, how would you describe your self-esteem? Right? How would you describe? So the blue are words that I have done with my patients. How would you describe things like decision making? Oh, I can't decide on things. Why can't you decide? I don't know. Or I feel worried about making decisions on my own. How would you describe your relationship with other people? And these are things that they come about. What about to regulate and direct yourself? I can't do it. When faced with difficulties, I shut down. When faced with difficulties, I break down. What about the common thoughts that you have in your head? So what does this slide do? This slide gives me factors for me to tackle when I do the problem solving with the kids or the young adults. Why? This is the other thing I think for some of you that have done cognitive behavior therapy, CBT, this is a common, I'm sure that you've seen this diagram before, right? There is a very fine line between what do you think and how do you feel, right? It's two different things. And what do you do, or how the body feels, right? We think and we feel, people think is the same, it's not. And I always say, feeling is how you feel, your emotions. Thinking is what you have in your head. The irony is they're not the same. And I always say, is there a switch for you to change your emotions? No switch. But you can change your thinking, right? How? So, okay, the outcomes is self-doubts, yeah? Self-doubts will definitely make you feel more negative. So these are things that I use. Now, this is what I do. How? Okay, let me show you how I do it. This is my problem solving. Yeah. I know my time is running out soon. Okay. Okay, so this is what I do with the patients, yeah, and I do it repeatedly because they come in with the same thing again and again, right? So let's say, okay, I cannot trust, so distrustful relationship, I cannot remember offhand an adolescent because I can remember yesterday that I have this young adult, distrustful relationship, yeah, and complicated by this traumatized childhood whereby I think she was 7 or 8 that she found out, or rather the family found out that father had a mistress and remarried and married his mistress and they have a child. So because of that, she's always has this anxious personality traits, right? Why? Because she never knows how the father comes in and he might be in a bad mood, right? Even though he has done the family wrong, right? And she never know when her mother is going to break down, wanting to seek help. So the triggers are, okay, the issues with the relationship. And then she said that my current trigger is also how I interact with my mom, because mom continues to put me down. Yeah. Okay. So then I talked to her about what are some of the content in your head. Well, I think this is really unfair that this has happened to me. Okay. I feel that a lot of things have been taken away, right? Including my mom. I never had my mom. All right. So then I get them to think about, but that's in the past, yeah? What about in the current, the difference? Now, if we don't make this difference or make them understand what is your thinking in the past and in the current, we think that everything is the current. But in actual fact, our thinking is from what we take from the past. 1, 2, in a relationship, in a traumatic childhood like this, yeah, remember what I said, yeah, they grow up feeling insecure, they grow up not believing in themselves, and this child has never been able to make decisions on her own because she's too preoccupied looking after the family. And therefore, yeah, to decide what is it that she wants, even in her course or what she wants to do in the future, she can't. She's afraid of the continuous battle that she will have to face. And this is why I have to keep doing it again and again to make her realize that these are thoughts that you carry from your past. What about the current? And you'll be very surprised. A lot of patients will say to me, I actually don't have any thoughts in my head. And the reason why they've not had any thoughts in their head, they've never been allowed to think about themselves. So can you imagine? Can you try having this idea of what happens to you when you have no thoughts in your head? You can't even decide what you want to eat. What do you want to eat? Don't know. Right? So at 22 years old or 23 years old or 30 years old, you don't know what you want to eat because they're not there. Right? They are there in the past. So that's why I put it down there, list it, so that they can see it. Right? Not just see it, but to make sense of why are you thinking this way? Right? So again, I have to keep doing it again and again. Okay? All right. I have about 10 minutes. Okay. Any questions for now? Oh, no, not questions. Any comments? Yes, I'm more or less finished.
It's okay, you can have the whole session to yourself, Dr. Aini. We are learning
Okay.
from you. Because this is very new to us. Oh, there is one.
So,
What is the child or teenager? What if the child or teenager remains silent or just answered, don't know, not sure, despite we are trying to explore more? Is there any tips to break it?
okay, who asked that? Kaylee. Okay, any tips? Okay, during my training as child and adolescent psychiatrist, when I was in Melbourne, believe me, my my consultant made me sit in a room with a child who doesn't say anything. And when I went to him and I said, Peter, she's not saying anything. And he looked at me. So what am I going to do? You're going to give her support. And in my head, what support? But believe me, this child, I sat with this child for 6 sessions, right? Every time I see her name, I'm like, oh my God. Okay. So when she came in for the 7th session, right? She said to me, are you just going to sit there and not say anything to me? I'm like, bloody hell. She said something to me. But because I wasn't prepared, I didn't know what to say to her. Okay. And she was this angry child, but eventually, right? So when somebody's, sometimes you get so, what I'm going to say, right? So I just said, I was wondering whether you have anything to say to me. And then out it came. What do you care? Right? I'm sure you're not going to listen to me. And then I said to her, hey, I've been sitting here for 6 times. I've been here, but you've not said anything to me, and I've not gone anywhere. And then we started having that conversation, right? Like, why do you think I'm not going to listen to you? Right? Why do you think that I'm not going to turn out for your sessions? Right? And out it came that, well, that's what's happened at home. Nobody listened to me. I see. Okay. Now, when I said to you in the beginning, this is how I do it. This is how actually I do it. And based on an understanding that children comes from homes whereby they don't get that. Okay. Now, many, many years ago, when I started doing child psychiatry, I had this 12-year-old child who was sent to me by my friend. And the reason was that the child wasn't speaking and he was depressed. Yeah. So he came in for therapy, and one day as we were discharging him, he came into my room, and then he said to me, I remember there was 5 p.m. He knocked at my door and he said to me, when are you going to stop acting? And I looked at him and I said, what do you mean? And then he said, you and your staff, you all speak so softly and nicely to one another. You allow us to speak, you're listening to us. So when are you going to stop acting? And I looked at him and I said, but we are not acting. This is how we are. So why do you think he's doing that? Anybody? Anybody? Because he doesn't come from from an environment whereby people are what we are doing in the unit. So he thought that we are acting. We are not. Mm-hmm. So they pelik why we are talking like this. Right? So when they come in to our room, I had one again, a new case on Monday, right? And the psychologist who said that she can't do anything because this child is not opening up and whatever it is. Yep. So this child came in and I was telling myself, okay, 7 o'clock, I'm going to sit in this room, 7 p.m. I'm going to sit in this room. What am I going to do if this child doesn't talk to me? And then she came in and I said, hey, it's already evening. You must be pretty tired. And she said, yep. She just nodded her head. And then I looked at her and I said, do you know why you're here? My mother brought me here. Okay. Do you know why your mother brought you here? And lo and behold, half an hour, she's already telling me how things are with her, so on and so forth. And she remarked and she said, I don't believe that I told you everything that I wanted to tell somebody. And I said, that's really good because I was afraid that you're not going to talk to me. Okay. So I want you guys to go back and figure out what is it that you need to do if you want to take on an adolescent. Okay. And if you take on an adolescent and you're able to do even small things with the adolescent, I tell you guys, it's great. It's really great because many of the adolescents, they are so angry. They're so sad. So these tiny changes that they see in you as a doctor or therapist, it is wonderful to them. Okay?
Doctor, is it compulsory for the parents to accompany the patients?
Yeah, kena. Because especially if you're going to give medication or treatment, any form of treatment, therapy, macam counselling for example, the parents kena agree.
Okay, must be there next to the
No,
patient.
no. I see the parents and adolescents separately.
Okay.
Okay.
Because I'm concerned about the parents who become too defensive, kan?
Yeah,
Afraid that they are being exposed.
correct.
Mm.
Yes. In the same way, the reflection and whatever it is, this is what I do with the parents. Yes, you're very right. Yes, I don't go in and say things like, kenapa you marah tak? So I use things like, so how are things at home? Now, one thing that really works, okay, but they can still be defensive is I do a lot of reflection, meaning to say things like, oh, you look very upset or you look very tired. And of course, sometimes they get upset. Ya lah, anak ramai ni, macam mana saya tak penat? Okay, all right. Yeah, then I say things like, even though in my head, but then externally I would say, yeah, I can understand why you're always angry. Okay, when I say giving it a name, right, I really try and figure out giving it a name. And I use things like, okay, I might be wrong, but I think you sound upset. Okay, and then they will throw it back. Yeah, you're asking me all the stupid questions. And then I will take a deep breath and tell myself, that's what, remember I said, I take a seatbelt, many seatbelts, and I will say, yeah, but if I don't ask all these questions, I would not know what's going on with you. I wouldn't know what's going on with your child. Yep. Okay. So remember what I said? Parents also comes from homes whereby they are very rough in their manner with the kids. Yeah, they're very rough in their manner, in their words, even with us. So please, guys, do not get offended. Even though sometimes I'm like, "Ugh!" Yes.
That's another skills that the doctors also must have, not to
Yes.
externalize our inner feeling. Kan?
Betul, you're right. But that's why I say let's do it for our kids. I can tell you, I don't know what normal is anymore. I see so many, really, kesian, right? Disturbed adolescents. Okay.
Okay.
So thank you for helping out.
All right. Thank you very much, Dr. Aili. Last opportunity, anybody wants to ask any question to Dr. Aili? Or just to raise your concern or share your experience, because this is our last session in the CME series. Okay.
Yeah.
Do you want to give any feedback on the CMEs? Feel free to do so. We have another 2 minutes before I end the session. And Dr. Aili, as a general advice with regards to psychiatric management in the clinic, in the primary care setting, what is your advice to the doctors in the primary care?
What's it? Sorry, apa dia?
Okay, as a general advice to the primary care doctors, whenever they manage the patients, the psychiatric patients in the primary care setting, what is your advice to them? With the limit of time, maybe limit resources, and also limit in experience. So how do you go about it?
Okay.
Your advice.
Remember when I said to you, okay, my ex-trainees will always laugh because they say it's not possible, but when they see how I work and when they try, it's possible. Meaning, we can try and figure out whatever problems there is within 5 minutes. So I'm left with that 25 minutes, literally. You know that boy when he said, please, you can stop acting. Sometimes I do play and act, meaning I speak nicely. I try and show patience. So I think the 3 or 4 slides, when does therapy starts? Therapy starts immediately as soon as I see the patient or I get the patient in the room, my therapy starts. Okay, why? Because mindful of the fact that I probably have 30 minutes. to try and make an impact so that the parent as well as the child comes back for therapy. Okay, even though I have this knowledge of so many years, I tell myself, don't. Stop to understand. When I stop to understand the child and I say, okay, tell me more. I'm trying to get the child to engage with me so that they come back for therapy. Try and do it. Okay, for me, doing child and adolescent has changed my life so much because it has taught me in terms of being humble and being human, right? So do it, try. Now, those slides that I gave, I purposely put some examples so that you can use it as a form of test, right? Now, those slides also, see, but because we put up an act before, but eventually it creeps into us. So when, the way that we ask, the way that the intonation, it goes with it. So your therapy starts immediately that you have the person that you are or volunteered to see, right? So believe me, it will work. Try from half an hour or 1 hour, 30 minutes. The way that you nod, the way that you say, it's therapy. Even though your nurse says, doctor, time. So, okay, what I do before is I have kids that really need therapy. I move them to another day where I have a bit more time. Okay, one is for my training in Australia, I make sure that I do have time, right? Time, it's nice to have 60 minutes, but if I don't have 60 minutes, I use half an hour. Problem solving. Do it, try.
Okay, it's a challenge to everyone, including myself. I might not have patience, psychotic patients, but I have my own children. And it's like implying the talking therapies to my children as well,
You're
kan?
right. You're right. Yes, Faiza, you're right. You're very right.
Yeah. Okay, thank you very much, Dr.
Thank you,
Eileen. I have learned
everybody.
a lot. All of us have learned a lot, but it's a matter of practice, yeah? And on behalf of the state of Selangor, I would like to thank Dr. Eileen, all the psychiatrists, and all the attendees who have involved in this CME. And it's good to have all of you around. And I hope we will have the opportunity again in the future to organize such session. Yeah. And on behalf of the state of Selangor, I would like to thank everyone and apologize for any shortcomings. Thank you very much from me, Dr. Faiza, and goodbye, everyone.
Bye.
Thank you.